Thank you for joining this AJMC webcast, Implementing Alternative Payment Models for Improved Population Health Beyond the OCM. This program is part of our continuing series to share experiences and best practices from a variety of perspectives. My name is Dr. Lalan Wilfong, and I'm the Vice President for Quality Programs in Texas Oncology. Joining me today are Robert E. Baird and Sarah Cevallos. Robert is the Chief Executive Officer of Dayton Physicians Network in Dayton, Ohio. And Sarah Cevallos is the Chief Revenue Cycle Officer at Florida Cancer Specialists and Research Institute and American Oncology Network. While I'm sure most of our audience is familiar, a little background for those that are not. The Oncology Care Model, or OCM, is a 5-year program launched by CMS in 2016. It's an episode-based alternative payment model for cancer care, combining the attributes and function of medical homes with financial incentives for utilization and quality outcomes. It is geared to focus on patients with all types of cancer who are undergoing cancer-directed therapy. This year, reconciliation reports were released by CMS to OCM participants, as well as a baseline report, which was eye-opening to many. Today, we'll be discussing some of the implications of this feedback on practices and what all this may mean for the future. Thank you again for joining us. Let's begin. To help set up our conversation and provide some context for our viewers, can each of you share a little bit about your background, role, and experience thus far with OCM? Robert, why don't you go first?
I'm the Chief Executive Officer of Dayton Physicians Network, and we're an independent practice made up of a multi-specialty group with radiation oncology, medical oncology, urology, and other ancillary services. We have multiple practice locations, and we have about 50 physicians and advanced practice providers. And in the Oncology Care Model, we're serving about 1,100 beneficiaries per month, per episode.
And Sarah?
Sarah Cevallos. I'm the Chief Revenue Cycle Officer for Florida Cancer Specialists and American Oncology Network. We have about 200 physicians throughout the state of Florida and 8 currently in American Oncology Network in 2 separate states, Arkansas and Louisiana, both part of the OCM. We have about 13,000 OCM beneficiaries. We started our venture in value-based care probably about 4 years ago with a private payer, and then got into the OCM because we felt it was really just a natural transition.
So Sarah, how did you accomplish your practice transformation to value-based care provider?
So I would probably say it's a work in progress. I think accomplished is something that we are constantly looking and striving to do. However, it is something that, through really enhanced communication, physician buy-in, it's been really a revolving process to make sure that we're adjusting to the OCM, we're making sure that we have the right infrastructure in place to support all of our physicians, all of our clinicians. So I wouldn't say that it's really accomplished. I would really just say it's something that's a work in progress every day.
Still ongoing. What about you, Robert? What has your practice done?
And I think similar to what Sarah was talking about, we participated in different payer pilots. We also were part of the CMMI Come Home grant. It started with 5 practices in terms of developing an oncology medical home. So we learned a lot from that experience, developed a lot of the infrastructure, a lot of the care paths and care plans that we have in now. And I think at that time, our physicians and our practice started to realize that healthcare really is changing, and we are going to focus more on a value-based model. So we learned from that, and we wanted to participate in the Oncology Care Model because we knew we wanted to be part of the solution and part of the transition, and not just have things dictated towards us. So we've been actively involved trying to educate our patients, educate our providers, educate our staff, and also make sure that we can make the program as successful as possible.
So what's working well? What are you proud of? And then what is your biggest challenge? Sarah, why don't you start?
Yeah, I think I'm really proud of the fact that our physicians are much more engaged now. I think when we started with a really small pilot program, it was, yes, that's coming, the future, it's, kind of, yeah, kind of Chicken Little type of situation happening. But the OCM really set a precedence with being 50% of our population, of our patients, that now the physicians are asking a lot more questions. What can we do to help? How can we get more involved? They've really, really developed a voice, and I think that's something to be really proud of.
That's great. Robert, what are you?
I think what's worked well for us are some of the changes we made to the workflow of our practice by implementing a nurse triage line. Also by making sure that patients have access. We started weekend hours and have weekday hours to make sure patients were able to come see our practice at an appropriate time instead of going to the emergency room or some other different site of service. And also, I think implementing and getting our advanced practice providers involved has really worked. Prior to getting in the Come Home program and also the OCM, we did not have very few advanced practice providers, and we've now been able to integrate them into the care of our patients in our practice.
Yeah, we've added hospitalists as well. So I think I've heard a lot of OCM practices have added hospitalists. So I think adding additional help has really, enabled us to be successful too.
That's great.
Yeah, and in addition, it's also allowed us to partner with other organizations, such as a local hospice organization and also a local palliative care group that's helped support our patients in our practice.
That's great. So those partnerships have been really helpful in looking
Yes.
at not just what you did on a day-to-day basis, but the whole continuum of care sounds really important as well.
Yeah, absolutely.
So what's been hard? What's been the most difficult thing to accomplish thus far?
Can I start?
Well, I think it's been, a lot of it has to do with communication and understanding what's coming. That's been one of the biggest challenges in our group is we've learned a lot about the program. CMS has had a lot of webinars and a lot of discussion about the oncology care model, but it's getting everyone to understand and get everybody on the same page. For example, when we first started the program and knew about the IOM care plan, the 13 elements, we had to design our EHR from the ground up to get there. And the other challenging part of that is to answer all those questions, we started trying to do coordinated telephone calls. But that became logistically a challenge, leaving messages for patients when they call back, you're busy. So that gave us the idea to bring in the nurse practitioners and the other advanced practice providers to start those types of visits.
That's great.
Yeah, I'd have to echo that. I think translating the requirements of the program to the practice is probably one of the biggest challenges. Adding on to that, I think another big challenge has been just the technology itself. Getting our EMR vendors to be agile as CMMI has been. So they've been incredibly responsive, which has been really positive that they're open to take our feedback and to adjust the program, and that's fantastic. However, it's very difficult to get the technology to support as fast and frequent as we need it because things are happening by the minute.
Exactly.
This program's not stopping to allow for coding changes. So I think that's been a challenge.
We're not going to even talk about quality metric reporting, which is a big challenge.
Oh, yes.
So both of you have very different practices. I mean, you have a lot of multi-specialty in your practice, and you have a very large practice. So what kind of educating and training did you have to provide to your physicians and other ancillary staff?
So it's been a lot of webinars, a lot of phone calls, a lot of meetings. We have regional meetings that we have to travel to make sure that we have that face-to-face interaction with physicians. ARMPs, how to read reports, how to understand and interpret, particularly the quality metrics that we have to put out. It's been a constant re-education, education, because they need to hear it a lot. They don't do it every day, and so we can completely respect that. But we have had to develop a team that has really just been all about value-based care education.
And that ongoing education is important.
Yeah, with the changes.
What about you?
And we've done some similar activities. We do calls, webinars. We actually have a physician we've appointed as the medical director of our Oncology Care Model. And we have a committee, a multidisciplinary committee that meets every other week where we discuss all the aspects of the program. We also take very detailed minutes and we share those out with our other providers and our other service lines. We've also, when we do our biannual physician meetings, we make sure that we present where we're at, what's going on. We give individual feedback to providers. So we do as much as we can face-to-face, but there's also the electronic communication with emails, conference calls, and things of that nature.
Right, that hopefully they read. So as we finish up this section, what key insights would you have for other practices implementing a program like OCM?
That you really need a dedicated team to make sure that they can translate the information to the clinical team and the operations team that's not in it every single day. We have the ability to be on the webinars that are in the middle of a working day for clinicians that cannot be on them. So we have to really make sure that we're providing that level of support. And like you mentioned earlier, the education, re-education, just over and over, it feels repetitive in nature, but you really need to do it because it is not something they do every single day.
Right.
Yeah, and just like we were talking about, it takes a strong physician leader, someone who really understands the value-based care model. It takes a strong administrative team to make sure you can get the operational policies and procedures in place, and then just a strong technical backbone in terms of IT infrastructure and people who can really work with your EHR to make any changes needed.
So it sounds like the whole team, the physician, the administrative support, all have to be committed to value-based care in order for this to work.
Definitely.
Earlier this year, practices participating in the OCM received their Performance Period 1, or PP1, initial reconciliation reports, and recently received the PP2 reports. These reports summarized actual expenditures and determined whether total episodic cost of care were higher or lower than CMS targets. For PP1, CMS reported that only 25% of participating practices were able to achieve a performance-based payment. That number moved up towards 30% for PP2. CMS also released that over 50% of practices were able to achieve a target below their benchmark. So what are your perspectives on this data? Sarah?
I would say that, it's definitely something that takes, I think we talked about teams earlier, a very knowledgeable team to really interpret and understand. The initial reconciliation results were definitely shocking for us, and even though we have kind of come out to the good side as far as, on very positive pay performance 2 results, it's still been something that we're still digesting and really kind of trying to understand what to do next in terms of actionable items within the data. We do know that CMMI adjusted a lot of the way that they did the calculations. So balancing that and understanding that, also what did we do well in terms of being successful in the program is something that, I think it really is something that we're working through.
Right. And I know it's very difficult to know exactly what improvements you've made that have led to success versus the changes in the model that have led to success. Do you have any perspective on that, Robert?
Yeah, so when we received, because the amount of data you get back, you get your claim files back, you get your performance-based, your PP1 report back, the amount of data can be overwhelming. So we did end up using an outside consultant to help us, again, try and figure out where we have areas of opportunity, where we're doing well at, and kind of focus in that area. So we were very surprised, like Sarah mentioned, when we got our first period results back, the PP1 results. And I think that was really the first time where everyone had the aha moment, where they're serious about this. This is really happening. They've got this data. They're measuring us to make sure we can improve the quality and cost of care. So we were very surprised at that, and I think that was really a call to action. That's when we really started, I think, taking some of the changes we needed to make seriously. So that data helped us come back, but it does take a lot of resources to understand and help guide you through what those reports mean, where you've got areas of opportunity, and where you're doing well at.
So you said that you noticed in your reports there were some areas of opportunity. How did you identify that and implement some changes to make better success in Performance Period 2? Yeah,
so one of the areas that, like you'd mentioned, they did make some changes in the calculation. Our practice, since we have urology, we do have about 50% of our practice is breast cancer and prostate cancer. So those changes did help us make some improvement. But when we went back and looked at the data, things that came out very clear were things like emergency room visits, that we knew we were falling short of the benchmark and falling short of the target in that area. So by implementing the nurse triage line, by also opening up access during the day for our physicians, making sure we have weekend hours, really helped get those scores more in line. We still have some work to do, but that's one example of where the data came back showing where we were at.
Right, and then you use that to implement changes to make performance improvements for the future.
Correct.
That's great. What about you, Sarah?
Yeah, we had a similar approach. We really focused on things that we can improve kind of outside of our 4 walls, because those are the opportunities that are kind of the hardest in a sense, right? So we put a pretty big care management program in place. We hired, I think around 70 or so full-time nurses that would be able to help manage those hospital admissions, those unnecessary ER visits. And that's really where our first focus went on. And I think, just kind of speaking off the cuff, because it's, again, we still have to analyze the paper performance too, that really had, I think, a big impact on it. I think, just hearing the feedback and even hearing just individual accounts of what care management has been able to achieve could have really potentially helped, with the turnaround of the results.
So Sarah, you'd mentioned that you have hospitalists
Yes.
employed by your practice. How many do you have, and where are they?
I don't have an exact number, but we're continuing to add them every day in our regions. I think we just added between 2 or 3 last month. But we have really helped, or really seen that has helped guide the patients and get them back into our offices and discharged much faster. And I think that has probably also had an influence as well. And you mentioned earlier about having hospice providers or outside providers. That's really helped our relationship with our other hospitals. We have a number of hospital systems that we have to deal with throughout the entire state and in multiple states. And that, I think, has really helped, because putting a full-time dedicated oncology hospitalist in place who knows how to take care of oncology patients, we really feel has made a difference.
That's fantastic.
I was just going to say, and I think that's an area of opportunity for us, because one of the things we've talked about is taking this data, and we've actually gone to our local hospitals and talked to the hospitalist groups there to say, hey, we need to work on this together, because we need your help, and of course, their needed reduced length of stay and other quality benchmarks they have on the hospital side. So we did find out that we have more in common than we thought. We just haven't employed a hospitalist yet.
Yeah, when we talked about training earlier, we actually did a special VBC training just for our hospitalists, so that they understood the program itself, because that's one of the main reasons why they're there.
And what was expected of them.
What was expected of them. And
yeah. So one of the things that just struck me is one of the aspects of this I've really enjoyed is the opportunity to talk to other practices and share ideas and success stories and struggles. Do you think this is something that other practices are finding useful for them? Are they excited about participating in OCM? Or do you think that people are starting to become disenfranchised with the program?
I think there's still some excitement to it. I think it kind of waned when everybody got their performance period 1, because I think most of the results were disappointing. And a lot of time and effort was spent to try and talk to CMS and CMMI about making changes which were positive. And then I've seen some of the excitement rekindled after the performance period 2. We were not successful in achieving a performance-based payment in either the first or the second, but we made a lot of progress towards that. So I think there's been some excitement coming back.
And to that point, one of the concerns I've heard about OCM is the delay in time from the performance period till you get your results. Do you think there's still time to make change? Is it too late?
I think there is. I think there's still time to make change. I mean, we're obviously a very big practice, but I don't think that the physicians are any less excited to see if they can really move the needle, even if we don't achieve shared savings. I think it's a point that it's making change in oncology and how physicians should be reimbursed.
Great.
Yes, and I would agree. I think there's still time to make change. I know we also monitor the performance feedback reports we get, which we just got our first quarter of 2018, and we've seen even more positive changes then by just comparing our performance feedback reports we get. So I think there's still time to make change, but it is frustrating sometimes when you feel like you've done so much and made so many changes just to get data that's
not showing
a year and a half old, and it's like, oh.
Yep.
Right. And so where are you moving to next? What's the next step for you as far as continuing to perform in these models?
Yeah, I think it's just continuing to find opportunities. I think the OCM is something that it's been definitely a learning curve, because it's really put so many patients underneath value-based care, whereas with our commercial payers it wasn't as many, so it wasn't as apparent to make it the top of your to-do list that we have every day. But I think it's continuing to develop those programs, the need to treat patients the way that we all want to treat them, we'll definitely keep evolving as we move forward with more programs down the road.
Yes, and I think it's been able to allow us to talk to some of the other commercial products and commercial payers. Also, we've been able to, again, learn quite a bit about the way our practice functioned and the areas of opportunity we had to really, truly put patients at the center, truly coordinate care, making sure that we're gathering all the data, that we're managing those patients and taking care of their needs very well. And I know there's other opportunities out there, and potentially other Medicare programs with the PTAC commission. There's a couple different payer models floating out there. I know COA is really pushing the OCM too. So we're hopeful that a program like this that can still continue.
And so they also released the Performance Period 1 TrueUp reports. Any surprises with that?
I was a little surprised, the drastic change. I didn't think that it would be as, I thought it was supposed to honestly, I just didn't think that the TrueUp would be that different. But it was, and I know it had a lot to do with the 90-day window that they readjusted, but yeah, I don't know, I wasn't as, I was more surprised than anything just of the change, but otherwise I think it still kind of held true to form.
Right.
But still, there was a number of changes just because of the patients who came in and out of episode were drastically different. So,
yeah, because ours changed also. It didn't get better, so it went the other way, unfortunately. And I think one of the areas that we were hoping is we spent a lot of time going back through all the patients and their medical record to see if there were areas that we could contest. And so we contested a majority of the patients on the first period report and had 0 changes to that. And so to have our reports come back, for the first TrueUp and not have any progress, it was very frustrating.
Does it make you nervous about PPT TrueUp and what changes you may see?
Well, if it goes in the same direction, I guess, as far as, because ours went the opposite way. If it keeps going the good way, then I'm okay with it. But I'm hopeful that it will remain. It will be less dramatic because we're not seeing any changes in how the patients are attributed. So that's at least from that perspective. But
and hopefully, as time goes on, they will become better and better at reporting accurately.
Right.
That's our hope.
Yeah, and not change the rules. Yeah,
Right.
Yeah. So.
Speaking of that, Performance Period 3 results are going to come out in a few months. And there are some big changes, especially with the breast, bladder, and prostate adjustments, which sounds like it'll affect your practice quite a bit. What are your expectations for Performance Period 3?
Well, we're keeping our fingers crossed that we're going to, cross the goal line and get a performance-based payment. We spent a lot of time and effort from Performance Period 1, learning from, particularly about the HCC scores or the comorbidities of patients, making sure that those are well documented, because we went back and looked and we were not putting a lot of that information on the claim. So we spent a lot of time and effort, and I know we didn't see any of those results yet in Performance Period 2, but we've been tracking our performance feedback reports. We do know that in the beginning our patients were all classified as low complexity on our most recent feedback report. We did bump that up to the next level. They're at least moderate complexity now. So we know those changes that we put in are making a difference. We just haven't seen them reflected in the Performance Period results. So we're very hopeful that Performance Period 3 will be successful for us.
Yep.
That's great.
What about you, Sarah?
Yeah,
Anything?
I think the same. I mean, we have a number of breast cancer patients as well, so I think along those same respects that we're hopeful too that some of those changes and those adjustments coming forward will be a benefit to us.
Right. Good. And so are there any other low-hanging fruits that you can go after? Is there anything out there that still left to do that's easy?
I know we're just reporting patient satisfaction now, and I was going to say, patient satisfaction is low-hanging, but it takes a lot of effort. I mean, our performance, our patient satisfaction scores that we're getting in the feedback reports, still have room for improvement. I know eventually that's going to be factored in to one of the pay initiatives, but we've realized, as much as we've been trying to do that, it's very, very challenging to move those numbers.
Yeah. I would say I'd say there is. I think within our practice there's definitely some, or any practice, there's definitely some low-hanging fruit. When you start touching, drugs in a more systematic format, I think with the changes of therapies, they're just constant. It takes, it takes some time and effort to do that, but, and I guess you could argue whether or not that's low-hanging fruit or not, depending on the
How difficult
practice.
that is.
Because it is a sensitive topic.
Right.
But I think at that point, I think there is, there's still opportunity within the reports, for
Right,
sure.
right. I know it becomes very difficult when oncology care is changing so drastically with all the new drugs, all the new indications, and where do you spend your time and efforts as far as making additional changes? And I think a lot of practices have seen the good things, the patient-centered care and reducing hospitalizations and ER visits. But I think getting them down a little bit is easy. Getting them down further proves to be more difficult. And so it's going to take a lot of extra work to continue to succeed in these programs, I think. So what changes have you made that have been the most impactful on your practice?
I think one of the areas that we've seen to have the most impact is we've implemented a weekly huddle process. A few months ago, after one of our OCM meetings, and we were just talking about how to really coordinate care, we came up with the idea of implementing a weekly huddle. So each week we have designated time on the physician's schedule where he pulls his care team together with the nurse practitioner, the medical assistants, the LPN, sometimes the administrative staff such as the front desk or the office manager if needed, and they go through their schedule patient by patient to talk about, is this patient high risk? Do they need additional resources? They go back and look through the support system that patient may need. Do they have upcoming tests that need coordinated or we don't have yet? Have they recently been in the emergency room? So it's really opened our eyes, and that's one of the thing that I keep hearing about in the practice that has made the biggest change. And we're still in the process of rolling it out. Some physicians are spending up to an hour and a half each week going through their patients, some a little less. But right now, we've seen a lot of excitement, and I think people are getting back to really starting to see some of the practice changes you can make can really impact the life and the health of our patients.
Right. And no, I was going to say that's fantastic, because I think a lot of times patients think they tell us something and they tell one of our staff members and that information is not shared. And sharing the whole continuum of care for that patient is so important for the patient's benefit, that everyone knows what all aspects are going on with that patient's care. So that's fantastic.
Yeah, because we've had one of our medical assistants was just telling me last week, as they were just sitting in the clinic area, and since we have multiple specialties, radiation, medical oncology, and urology, somebody was talking about the patient with radiation, who's the medical oncology patient, and she said, wait a minute, I know about that. And
Right.
so they had a quick conversation about the care of that patient, real time.
That's great. What about you, Sarah? What's been most impactful?
Yeah, I think in the same respect has really been our care management department, and being able to, like you said it perfectly, sometimes patients don't want to, tell their doctor,
Right.
wait, I have a question, because they're really busy, and we don't want to interrupt them, so they'll come home and immediately call either the care manager, or the nurse to say, the doctor said this, but I really didn't understand it. Can we have another conversation about it? And I think that has really kind of closed the gap in education for the patients. And I think that's, as we continue to build that infrastructure, it will continue to have an impact on the patients, not just on answering clinical questions, but accessing them to additional financial assistance if they need it, if they have concerns about getting a ride to chemo, because they don't want to, they're embarrassed to
Right.
tell somebody in the office. Our care managers do all of that. So I think that's really made a huge impact on us. But moving forward, we're really, we talked about low-hanging fruit earlier in drugs. We're really looking to do some type of cost containment, like disease focus. So we're focusing right now on lung, because it's just been it's highly impactful in
Right.
our area. So we're going to do more of a regional type of program, because healthcare is local.
Right.
And having all these conversations with these different regions, with different areas within our practice, we've really found through just conversations of the different opportunities within each of the markets. So I think giving ownership to the regional and local team, I think will really make a big impact moving forward as well.
Right, and really focusing on drug and drug utilization, which is becoming much more of a part of the total cost of care. I mean, in our practices, it's 50 to 60+% total cost of care is drugs related, so we have to address that at some point. Absolutely. And how to utilize our drugs more effectively. I think I hate to give CMS credit, but I do think this program has brought our practices back to having patient-centric care and really making us think about what is in this for the patient versus for the other providers, and having us come together to really focus on our patients.
No, I agree. I think like you mentioned too, the 60 to 70% of our utilization is on drugs, and it's going to keep going up because we're going to keep wanting to bring these patients back into our offices because that's where the lowest site of service and care is, the cheapest. So, and we feel it is the highest quality too. So we want to bring them in, and it's going to get more and more. So we got to really make sure that we're focusing in on there.
Yes, definitely. Thank you for sharing some great insights on working with the OCM. Now, as we close up the conversation, let's talk about where the program is heading. For practices not achieving shared savings through the OCM, CMS has a budget-neutral pay-for-performance option in which some practices are penalized and others are rewarded, a two-sided risk model. So Sarah, as a revenue person, what are your perspectives on the two-sided risk model?
Well, not to be repetitive here, it's risky, particularly when you don't have access to real-time data. So it is something that you have to weigh those very carefully and calculated. And I know in our conversations earlier, we're a big practice, so we could take some errors, right? We could take some outliers. Right. Small practices might not be able to do that. So that is something that you have to really carefully consider and calculate. And if you feel comfortable and confident that you have a really tight ship and infrastructure in place, then go for it. You know, there's risk in it, but it's there and for the taking. You can lower your target and have a less hurdle to jump over. But at the end of the day, it is a risk nonetheless. So I would say in that token that it really is dependent upon whether or not you have a really good team in place and you're comfortable enough to take it.
So Robert, you actually have to write the checks.
Yes.
What would you need to go into two-sided risk for your practice?
Well, at this point, two-sided risk isn't feasible for our practice. We just cannot take that chance of the 20% potential downside. It would put our practice out of business if we had to pay that entire amount back. So I don't think that, as good as we can get, as Sarah mentioned, the data you get back is not timely, so you're being held potentially responsible for something you may have changed, and fixed a while ago. In addition, there's a lot of complications in just making sure the reconciliation's done correctly. When we received our billing reports back, our MEOS reports, we had to reconcile, a few hundred patients, and it gets very challenging to go back. So you, not only in addition to the potential downside, you may not even be able to count on some of the upfront money you've got from the MEOS payments. So I think right now it would be very challenging for our practice to accept that risk. And a lot of the other practices I've talked to feel the same way at this point.
Right. And I think one of the things we mentioned earlier was the difference in the PP1 report and the TrueUp, and then we have PP2, which is even more different. And it would be very difficult for us to take two-sided risk until we see really what the trends are and have consistency in that reporting to feel that you were making judgments that you could count on. And I think you brought up a good point too about the 20% downside risk. It's a significant amount of money for practices. How do you even go about accounting for 20% downside risk? Is there a way?
Well, you have to make sure you're reinsured, get reinsurance, and then I think this could also, and I think that's why you're starting to see some of the larger groups come together and things like American Oncology Network, because for a small practice, they can't take that risk on, but a larger entity potentially could. So this might, if you're forced into two-sided risk, it might force more practice consolidation into other private practices.
Right. Or into other systems.
Or into other systems, that's a good point.
So what would this take to be a desirable option? What would you, Sarah, have to go to your practice leadership with and say, okay, I'm ready to take two-sided risk? What would that take?
I think a few periods of seeing a trend, like you mentioned earlier, we started seeing the really positive trend in PP2. So I have to really start seeing that. The practice would, I'm certainly one perspective, but we have a lot of physicians at risk and they're all taking it, as a group. So I think it would take that, some some consistency
Right.
in the trend moving in the right direction, some positive momentum for the doctors to really see the motivation and have a bit more confidence in that in order to do that.
Right. And then is there any level of risk? I mean, we mentioned the 20% downside risk as being a lot. Have you thought at all about what an acceptable level of risk may be? It's a very difficult question.
I would say 0%. Just the upside would be great.
That's right. Just leave it as it is.
Yeah, just leave it as it is. No, the 20% is too much. I could see some type of shared risk where you don't have to pay things back, or maybe you have a withhold
Right.
or something I've heard about up front. More tied towards quality metrics and not just what seems to be a punitive downside risk.
Correct.
Of that size. So I could see a few percentage points being held back in terms of a pool,
Right.
but not the downside risk the way it's structured now.
And one of the things a lot of practices have told me is they're concerned about the cost of drugs and how much of an important part of this model it is, because the drug costs are really out of our control. So what changes would you make and suggest to CMMI as far as moving forward to make practices comfortable with taking downside risk and changes in the model that you may see make it even more successful?
I think if you do remove the drug expense from the equation, we want to make sure we don't limit any options of treatment for our patients.
Right.
And we are a practice that uses about 70% of our spend is on drugs. So we've seen that cost reflected in the PP1 and PP2 reports.
Right.
So I think holding us accountable for the price of those drugs needs to be changed. I would like to see that removed from the equation somehow, and that we're more responsible for the care and the management of our patients.
The things that you can actually control.
Things that we can control.
Yeah, and if it's not necessarily, holding the physicians accountable for the cost of the drug, shifting it to a utilization type of program versus, if a patient is they're using the therapy appropriately
Correct.
and they're not overutilizing it, nobody should be penalized for that, to your point.
Right. So utilization management program versus us being held solely accountable for the cost of the drug. Sounds great. What other changes would you make?
I would say that, my managing partner says this a lot, but really having more emphasis on clinical research and clinical trials. That is something that is, in our name, Research Institute. We really feel like that's making an impact, not just on the quality of care, but, it's impacting the future of finding a cure, right? It's something that we're all passionate about. So I think with that, there should be something in the program that emphasizes that a little bit more, because I truly do believe that brings a huge benefit and quality to Medicare patients, or all cancer patients, really.
Exactly. I mean, less than 5% of the population ever go on a clinical trial with cancer, especially the elderly population. And that's a very interesting perspective of what can CMMI do to incentivize practices to be more fully participating in research programs.
Right.
It's very interesting. What about you? Any thoughts about what else you would change?
I think some of the quality data reporting right now, as everyone who's in the program knows, it's a very labor-intensive reporting methodology they have. We end up having to do a lot of hand entering of the data, a lot of review of every one of those medical records to just catch patients who are on the exclusion criteria. So it's been very challenging, particularly like we were talking before, with the electronic medical record we're currently using is not oncology specific. So we've had to design and develop everything to put into place to meet the requirements of the OCM. And one area that really falls short is the ability for us to electronically get that information into the portal. And that just creates a very large burden on the practice.
Yeah, I think you mentioned earlier too in the conversation that with whether or not people are still motivated to be in the program, I think that those first 6 months to a year, everybody was so focused on how the heck do we submit quality metrics.
Right.
Nobody was really focused on how to actually change behavior and implement the program. I mean, one of the main objectives of our EMR vendor the first 6 months of the program was how to get a care plan electronic, and I'm like, that's not the spirit of the program. Like, that's a great tactical administrative thing to do, but the spirit of the program is really how do you change how we're practicing and doing it and bringing more value to our patients. So I think since that hump is over, it still needs refinement. it's a ridiculous amount of time that we have to reconcile 13,000 patients every single episode. And report on those, and then they change them and remove them halfway through, and you've been submitting quality reports to your physicians for 6 months, and you're like, oh, never mind, you can ignore those now, which is great, but still it changes the technology, and then it changes the focus too. So it's a lot to bear as far as the administrative things that I think could, to your point, Robert, be streamlined even more to allow us to really focus on the program and the intention itself.
Agreed, and I think making sure the quality metrics actually reflect what is good patient care and things that are applicable to improving patient outcomes is important. And to your points, I think very well taken about the administrative complexity of reporting those metrics. And the other thing that you brought up earlier was attribution and the MEOS recruitments and understanding which patients are actually in the program and out of the program. That seems to be very difficult, and making some changes that make that more readily apparent in real time would be very, very helpful, at least for us. And as we finish up, you're in other value-based care programs. You've done the Come Home model. You've done some payer initiatives. What lessons learned from the OCM would you take back to those other models and say, when you go to your next payer and say, okay, hey, this is something we've learned. How are we going to structure this program with you?
I think the commercial population and the payers themselves are very different from the Medicare population and the model itself. I think one of the lessons is don't make things so complex. And we've taken that lesson on to our commercial payers, and luckily they've been very receptive to that. All of our commercial value-based programs are very different. They have a different feel to them, but they're still total cost of care, same theme. So our operations and our clinical team, we don't translate them differently in terms of how to take care of those patients. They're all value-based care patients.
And aligning the program metrics with what you're already doing is very important to reduce complexity.
Yep, and that's exactly what we've brought back to them. It's like, okay, this is the very large list of OCM measures. Let's take 2 or 3 that we really feel are impactful, and really focus on refining those, and being able to adequately report on those as well. That's been really, really important to us, because manual intervention is just it's a game changer. You just can't do it these days at all.
Very difficult. What about you? Any thoughts about other payers and how you would approach a model with them?
Yeah, and we've had similar experiences as Sarah was describing. We have been talking to commercial payers, and we do have some value-based contracts, mostly around the total cost of care with some type of shared savings component at the end. And what we've found is that a lot of the metrics that we're tracking in terms of like emergency room, inpatient admissions, length of stay, hospice, are similar across all of those contracts. What's different is our commercial contracts aren't prescriptive. The OCM is a very prescriptive program, as it will be structured this way and you will do these things, where on the commercial side it's more of here's your targets and you develop the best way for your practice and your patients to meet those objectives. So I think what we've tried to do is make sure that we're not doing a lot of extra work with those other payers, and they understand that too, because what they've realized is how administratively burdensome it is on the payer side to manage these contracts also. So they get it, and they understand that you can't create something so complex, that takes the, amount of resources in a private setting that it does, versus the OCM, the Oncology Care Model.
Right. So as we wrap up, so OCM is going to end in 5 years. Some practices may be sooner than that, but it is a 5-year program. If you could tell CMMI what you're ready for next, what would you tell them?
I think we would like to let CMMI know that we're interested in the program in some aspects going forward. There's been a lot of talk that this might be the new way that oncology care is reimbursed in the United States, from Medicare. And we would just like to make sure that they listen to us and take out the parts of the program that are working. Some of the care paths we put in place, some of the documentation requirements are working, but then some, like we talked about, the quality metrics are just more burdensome and maybe not as meaningful as they could. I also need to make sure that there's adequate funding in place. This does require a lot of infrastructure, a lot of resources to manage very complex cancer patients, to make sure they're taken care of in the best highest quality and lowest cost setting. And if we don't have the resources supplied to us, those patients may move into higher cost of settings, have more complications, and then just quality of care can go down from there.
Yeah, I agree. I think protecting community oncology practices, like you mentioned earlier, if those smaller practices take downside risk and they're forced into other systems that are even more expensive, it's not going to be a good outcome for anybody. So I think continuing on with a similar theme that has a different, a little bit different as far as infrastructure requirements could potentially,
Correct.
be a positive for everybody.
And continuing to financially support all of the practice changes that we've made to improve patient care is important.
Absolutely.
This has been a great discussion, and we've covered a lot of ground. Before we end, I'd like to ask each of you for any additional insight regarding the current and future state of the OCM.
I would say that this is really just the beginning. I think that value-based care is something that has been in the works and has been, a term that's a token that's kind of been thrown around for a lot of years, with the come home model and all the other, kind of preceding programs that we've seen and even in other specialties. But I'd like to see the theme continue, and I hope that between CMMI and other, big payer advocate groups and so forth, that we don't this isn't just something that's here temporary. I think it's not a trend. It's not something that we should really look the other way, because the cost of healthcare is going to continue to rise if we don't keep pressing on in addressing the issue. So I don't know if it's insight really were to say that. I feel like it's more optimism, in that I think that we're going the right direction. We're talking, and I've been negotiating payer agreements for over 10 years now, and the conversations have really changed, and I'm really optimistic to see that payers are coming to the table and collaborating with providers. And I think that's the only way that it's going to change is by continuing that collaboration, getting conversations like this going, and keep pressing forward, getting patients involved and so forth. But I think from that respect, it's really just the beginning to get us to move forward to the right place.
Yeah. What about you, Robert?
And I feel optimistic also. I think there's been a lot of communication and dialogue opened up between the Oncology Care Model and practices, with other national organizations such as, COA getting involved. And I think there's been an openness on both sides to really try and make the program as it's structured now, with tweaks around the edges and tweaks, in terms of some of the methodologies used and some of the information that's gathered. So I think that's, made me more optimistic about how it goes in the future. I think one area that I'd want to make sure that happens is when we come to the end of this, if you have to, that there's some relief given if a practice truly cannot go into two-sided risk, that they could still stay in the program. I think that I'd like to see that going forward. I also don't think that you can cut off funding in 5 years. Everybody involved in this program has made significant changes to the infrastructure of their practice, put a lot of resources in place, hired a lot of additional staff. And if this funding goes away, the MEOS payments and the potential for a performance-based payment, practices will be impacted. As one of the practices that was in the Come Home grant, that's exactly what happened with that grant. We spent a lot of money and a lot of resources and a lot of time setting up our practice to be successful in that program. And when it ended, we had some hard choices to make, because we had put in a significant infrastructure, put in different processes. We did make the decision as a group to go ahead and continue to fund that, but it did affect the compensation of the practice. It affected the compensation of the physicians, and we had to make cuts and hard choices in other areas. So I just think cutting the funding off at the end is just going to be a very hard transition for practices to make.
Yeah, I think that's an important point to make, how do you prepare for the next step? How do you bridge between what's happening now and what's going to happen next? And I think I'm glad that we're asking those questions now and starting those conversations now, because it's going to take that much time to prepare for it, because of just the nature of the beast is medical care is complex, not just the treatments itself, but the administrative background and oversight that it takes for the people behind the scenes, like administrators and CEOs and so forth. So I'm glad that we're having the conversation now to start the discussions.
Right.
And it would be very challenging for that burden to shift to all the commercial payers. There's just, Medicare's half of our patient population, and that's really a hard, the private payers cannot make up that infrastructure cost all on their own. They need some support from the Oncology Care Model.
Because once practices have changed and transitioned to really focusing on patients and hiring those additional resources to improve patient care, it'd be very, very difficult to pull that back. And then to maintain competitiveness in the marketplace, to be able to fully fund your physicians and other staff in order to do that work is very important moving forward. Well, thank you both for your expertise and your insights. Very appreciate that. And on behalf of AJMC, thank you for joining this program today.